Good evening, everyone. I would like to warmly welcome you to our international webinar. And my name is Patrick Markowski. And tonight, on behalf of myself and also Kurara Noritake team, I will be moderating this webinar for you. And we are also happy to have such a large audience. And I'm confident that you will have a pleasant and educational experience with us tonight. Also, one important information to those who would like to listen to the webinar in Czech language, please follow the link which will be displayed on the screen below. And I assume that everyone here is already familiar with Kurara Noritake and also our materials. So just to make a long story short, we are the company shaping the future of aesthetics and adhesion. And we truly believe that our reputation is built on the materials such as a legendary Panavia resin cement and also highly popular 10 MDP monomer, which has been around for more than 40 years already. And of course, if you are interested in further information about the technologies we have and also what we already implemented or our portfolio of materials we have, please visit the website of Kurara Noritake Dental and follow us on our social media channels using the same name. Well, it's not about the company itself, and now it's time to introduce our guest for tonight's webinar. Please join me in welcoming Dr. Wiktor Pietraszewski.
Hello,
Hi,
good
Victor.
evening. Hello, good evening. How are you?
How do you do?
I'm good.
I'm good. Perfect.
Had a busy day at work, so I'm back and raring to go, and hopefully all of you enjoy today's webinar.
Okay, I'm really happy to hear that, and I'm so pleased to have you here on board with us with Kurara Noritake team, and as I think that we're gonna talk about aesthetic and long-lasting restoration based on your experience using various clinically proven materials. So I will just inform our audience about some technical background, because it's also important that we have a live session. So please be able to ask a question, and I will be more than happy to receive lots of them. And of course, we will start the Q&A session afterward, where we will provide you the answers. So, Dr. Wiktor, I think that we can start. So at this moment, I would like to hand over to the Dr. Wiktor and wish you a pleasant evening. And of course, let's be active, and I wish you good luck.
Thank you very much. I'm just gonna get ready to show you the presentation. So let's get into this. Perfect. Good. So hopefully all of you can see the first slide. Thank you so much for joining me on this sunny evening in London or wherever you are around Europe. It's such a pleasure to be doing this for Kurara Noritake. And I know most of you, like myself, have been to work today. Maybe some of you have got kids, maybe some of you are tired, but let's have fun and learn hopefully some new tips and tricks from today's presentation. And I'm very excited to share some things with you guys tonight. So let's start with my journey. I went to university in the University of Leeds. I got a human physiology degree. Then I studied dentistry in Poland, in Łódź. And I currently work in Fulham Road Dental, Surbiton Dental, and I have actually worked in 3 different countries. So I've worked in Poland and in Malta and in the UK, and I've had the honour of being a key opinion leader for Kurara Noritake since about 2022. So I'm very privileged to be speaking here today. And a couple of weeks ago, we got back from Japan. So there's a whole team of us from Europe, from Kurara, who went over to Japan, and I was very honoured to do a lecture, a presentation there. We managed to visit some factories, and we learned a lot of new things. So hopefully we'll be able to share some of the things we learned on this trip and show you some of the materials. that we use in everyday practice. So today's lecture is going to look like this. Today's webinar is going to look like this, and this is the breakdown. So it's going to be broken down into 5 chapters. The first chapter is called Restorability Assessment. The second chapter, Stabilize and Rewall. We're going to touch a little bit on endo. We're going to then move on to the indirect prep, what we do after root canal.
I'm sorry, Dr. Victor.
Yep.
We cannot see your screen. Can you please reshare your screen?
Sure. Can you see this screen now? Halo? Prezentacji nie widać. Dobra, czekaj. Kurde, co się dzieje? No ja wiem, wyłączyłem. Teraz widać? Mam zacząć od początku? Okay. Okay, apologies for the technical errors. So yes, so let's start again. Let's start afresh. So welcome to this presentation. I've got the honor of talking about this topic from rewall to restoration with the help of Kurore Noritake. And I'm just going to start by telling you a little bit about myself. So I qualified from dentistry from Poland. Before that, I did a BSc at Leeds. I studied human physiology, and then I currently work in London at 2 private practices. My main focus of practice, my main scope of practice is restorative dentistry. I've actually worked and practiced dentistry in 3 different countries in Europe. So in Poland, in Malta, and in London. So I've tried loads of different materials, seen loads of different cases, and I'm very excited to share everything with you today. I've been a KOL, so a key opinion leader for Kurore Noritake since about 2022. And recently we just got back from Japan, and that was an amazing trip. I had the honor of being invited to go visit the factories to do a presentation there at the head office. We met all the brains behind the materials that we use every day, that we know and love. So hopefully you'll find this presentation very useful. But the breakdown, so let's go through the breakdown of this presentation. So chapter 1, restorability and assessment. And then we're going to move on to stabilization and rewalling of pre-endo. And then we're going to touch on the root canal treatment, indirect preparation, and then indirect fit. And we're going to use this as a kind of breakdown of the whole presentation. And this is called my treatment line. And I always have this in the back of my head when I first see a patient. And you can see here, there are many steps. And then on the line just below the blue line, you can see how is this broken down into appointments. And just keep this at the back of the mind when we're going through this presentation this evening. We're going to focus in particular on one tooth, and that's Catherine's tooth. She's a long-term patient of mine, and she came in last year and we treated this tooth. So just please remember this photo, remember this tooth, because this is going to be popping up throughout the presentation. And we're going to go from its pre-root canal journey to when we fit the ceramic restoration. So we need to touch on the reasons of root canal failure. So there's loads of them, and based on this paper from 2016, these are the main ones. So persistence of bacteria in the intracanal and extracanal space, inadequate filling of the canal, overextensions, improper coronal seal, untreated canals, iatrogenic procedural errors, complications of instrumentation. All of these are very important, but a lot of them from the root canal side, from the specialist side. So we're going to focus on two which restorative or referring dentists such as myself can influence, which are improper coronal seal and persistence of bacteria in the intracanal and extracanal area. So let's begin with the restorability assessment. So this is very important, and I don't want to kind of let everything else overshadow this. So this is the initial consultation. This is where we take the records of everything. And this is where we need to ask the question, can this tooth be saved? And I'm sure you've had patients, all of you who are listening tonight, that patients come in and they always ask this question, does this need to be pulled? Does this tooth need root canal? Can you just do a filling? And this is what we're going to go through right now. And I think it's very important to follow all of these steps when assessing a tooth. So 3 kind of phases of assessment. You've got visual, photo, and then a radiograph. And all of these play a part in assessing the tooth properly. So when we do a visual assessment, we need to first of all identify the problem. That's the main and first thing that we do when a patient is in our chair. So we need to ask the patient about the history of the tooth, about the history of the pain and discomfort. We need to test the palpations, soft tissues around it, the tenderness to percussion. We need to do a biting test, test its mobility, test the probing around the tooth, test how it reacts to the cold. And if you can, do an electrical pop test. I don't always do one, but if you can, it would be great if you could. Then the next stage of the assessment is a photograph. And I love photographs. And if you see my Instagram, I'm obsessed with dental photography. But this is very important. Just taking a photo of the problem. This way we could quickly take a record of the problem. This not only records the problem, but it also allows us to communicate the problem, not only to the patient, but to the specialist that we will be referring to. It doesn't take very long. Please use a narrow buccal mirror for this as well. And then finally, a radiographic assessment. This is compulsory, and a bite wing and a PA, both of them are usually recommended. In this case, I've got a PA, and then we need to be able to see the whole long axis of the tooth and the apical areas. And with all of these three conclusions put together, visual, photo, and radiograph, we can come up with an initial diagnosis. And in this case, we have a chronic apical pathology, probably caused by the filling leaking over time and by the poor root canal treatment, which wasn't really completed. This patient came to see me, and the patient's old dentist was saying that everything was fine, that there was no problem. So the first job that we have is to gain this patient's trust. This patient wasn't aware of any issues. So she came to see me as a new patient. She didn't have any pain. She didn't know that the root canal hadn't been finished. We can see using the x-ray that there's a suboptimal root canal treatment. We can see using the photo that there's a failing restoration, and then we can tell from the history taking and from the visual assessment that there's no sort of intraoral, extraoral swelling. There are no symptoms on the tooth. This tooth doesn't have any mobility. And sometimes in the past there might have been some symptoms, which she did mention, but they seem to just fade away. So she didn't come in specifically for this tooth. But doing a correct assessment will help you discover problems like this in a patient's mouth. If you look at the photo a little bit closer, you can see that there's a large filling on this lower left 6. It's a large OD filling. You can see that the margins are discolored. You can see on the tooth next door, there's a small old restoration that we might want to explore changing in the future. But you can already start thinking after taking this photo, and you can start assessing your photography. You can look how you might have some undermined enamel walls. You might have some, you might already start thinking about what kind of restoration you will need to restore this tooth. So that's why a photograph is so important. Then, like I've mentioned already, you start thinking about what type of restoration you could possibly do on this tooth. And I try to onlay as many teeth as I can. And then this is in root canal treated teeth, vital teeth, it doesn't matter. I try to be as conservative as possible. Sometimes, though, you need to do a crown. You have no other option. Most of the time I replace, and this is when I do crowns mostly, is when I'm replacing old crowns and putting a new crown on. But when I do a crown on a tooth that's had a root canal, I look at mainly these features. So I look at the natural tooth remaining, how much of the tooth will be remaining after I've removed the old restoration. I look at the soft tissues. I look at where the finish line is, if it's supra, if it's subgingival. Big question as well, can I isolate this tooth well? Because if I can't isolate it, I'd rather just go down the conventional route and prep it for a crown. Are the margins deep? And do we have enough sound enamel and dentine for adhesive dentistry? That is very important. This is how it looks like when I'm in the room in my surgery talking to a patient. I bring up the photograph on the screen and then I show the patient and I explain to them that this tooth is discolored, this filling is very old, this filling is very big and weak. And by having the photo on the screen, the patient can understand this. I show them the x-ray as well, I show them the infection, and I try to discuss all the options. And you need to mention that, you need to be honest with them. You need to say to them, look, we either restore it, we do root canal and we save the tooth, or your other option will be to get the tooth removed. You have to ask certain questions as well. Do you get food trapping here? How does it affect your daily life? Can you see the difference between this tooth and a molar on the other side, for example? And do you understand why this is not just a simple filling replacement? Then you wait and you stay silent and you wait for the patient to ask questions. And this way, from a patient that you've never met before, in 1 hour consultation, you've gained this patient's trust. So let's move on to the next part, which is probably the key part of this presentation: stabilize and rewall. So this is where we do a further assessment of the teeth. We remove the caries, we prep the cavity, we rewall, we extirpate or we don't extirpate, and we temporize. I don't do root canal treatment. I've stopped doing it for about 12 months now. I don't do any root canal treatment. So 95% of cases, I refer to my specialists. And you might be asking, why do you need to rewall or prepare a tooth for root canal treatment? And there are many reasons, and these are the main ones. So we need to remove the caries. We need to assess the tooth further, because sometimes just by looking at the radiograph, at the photograph, you cannot assess the restorability of the tooth. We rewall it for the patient's comfort, because if you put in a temporary and that breaks, they might need to, or just a temporary without rewalling the tooth, that might break. The patient might need to come back. It does in the end reduce treatment time, and there is a more stable interim period between you rewalling the tooth and then them seeing a specialist. And then I think we do have a better prognosis long term. And this is how I think you guys should think of a natural sound tooth without any work on it. It's a bit like Wakanda, where we've got a nice protective shield that no one can see, and it's protecting the Wakanda, the home of vibranium inside that tooth, and that is the pulp, and we want to protect that. And if that shield is broken, then we're going to have problems. So this is how we want all of our restorations to be. This is how we want our natural teeth to be. So we want to try and emulate natural teeth. When we have leaky restorations or a decayed leaking tooth, they're a bit like Helm's Deep. Everything's going on, it's crazy. You've got bacteria attacking you from all ends. You've got occlusal interferences, maybe. You've got forces going nuts, cracks developing. Everything's happening all at the same time. There's no stability there whatsoever. So when you next look at a tooth, I want you just think of Wakanda and Helm's Deep. And would you rather your tooth be Wakanda, or would you rather be at Helm's Deep? Okay, that's to put it in really simple terms. And if we don't do anything, this will happen. And then suddenly there'll be a massive problem. And usually these problems are asymptomatic. And then suddenly there is a flare up. Then the patients are angry that you didn't tell them anything. So it's really important from the assessment, from the first time you see the patient, you let them know. And I'm sure that most of you have seen cases like this come into your practice. And this was a case from a few months ago where a patient came in as an emergency, end of the day, I was extremely tired, 4 o'clock, and the patient said, look, listen, I've got pain from my tooth. I was told a few months ago that I needed root canal, but I didn't go ahead with it. No reason was given. And I said to him, look, listen, you do need a root canal on the tooth, but you've got loads of decay in it. You've obviously got an open cavity. We should do something here first before you have the root canal. And my job here and our job as dentists is to get this tooth ready for root canal and get the patient out of pain. We don't want to do root canal treatment on teeth that look like this. And moving forward, this is a tooth that I saw on Monday. This is a patient that I saw on Monday. And this is another example where something was done, but only a temporary was placed. And this again was an emergency appointment. She arrived at a different clinic. She said her tooth was in pain. They removed the old restoration and then they just placed a temporary filling. However, the tooth wasn't stabilized. There wasn't effective caries removal. The undermined thin walls were not reduced. There was no rewall. And then the mesiopalatal cusp ended up fracturing. And then this tooth, because it's a subgingival fracture, this tooth, unfortunately, probably isn't restorable just due to the extent of this fracture. And this is just because a temp was placed. So going back to Catherine's tooth, we want teeth like this to be stabilized. And this is what I explained to her. So we want them to be stabilized first before they go anywhere to see a root canal dentist. If you do the root canal, this is great as well for you to be rewalling the teeth. And then these are the steps that I follow. So we get the rubber dam on, we numb the patient, we get the rubber dam on, and then we've got nice, good isolation with a good heavy dam. This is iso dam. Then I start removing the caries, the old filling and the caries. I start cavity prepping, and you can see that there's quite a lot of decay underneath that old restoration. And take a photo. If the patient is still, if you still haven't gained their trust, just take a photo during this stage and then you can show them afterwards. You can see where the root canal has been started but hasn't been completed in just one of the canals. And then you continue cleaning the tooth. You remove as much caries as you can. And then with the help of caries detector dye, you can do that effectively. Caries detector dye reacts with the caries and then it shows up really bright red or bright pink. So then you know exactly where the caries is and you can remove just the infected caries within the cavity. Then I rewall the tooth. So this is the important stage. In this case, I used a Pro Matrix and I just apply the bond on this surface here. So I'm using a self-etch bond from Curare called SE Protect, and I'm applying this here on the distal wall. And then I build up the wall. And I can use whatever material you want. This really doesn't matter. As long as it's a good, decent composite. In this case, I used Clearfill APX and used a little bit of flowable just for that margin right at the base. And I'm lucky that I had the luxury in this case of having the patient booked in directly after my appointment for root canal treatment. So all I had to do at the end of this treatment was to place a bit of PTFE tape into the cavity, and the patient literally got up from my room, walked a few meters and sat down in the root canal specialist chair. And if you don't have this luxury, what you need to do is build up the tooth as much as you can and just place the temporary restoration over where the entrance point to the root canals is. And then in this case, we've managed to make decent contacts. You can see that a lot of this restoration is composite, not only the wall, but the interior portion of the restoration as well. And then we've just got, this is an upper six. This is just over the mesial portion of the tooth where we've got the entrance to the canals. And it's nicely sealed. We've got PTFE under that GIC. And just compare it to this. Would you rather have this, like on this picture in the circle, or would you rather have the picture where the tooth has been rebuilt and you've just got the temporary restoration right in the center. We're going to touch on a little bit of endo. I'm not a specialist, like I've mentioned, but what I want to talk about is how the root canal treatment appointment looks like, how I refer to a root canal dentist, and what I ask my root canal specialist to do post root canal treatment. I'm very lucky that in Fulham Road Dental, in one of my practices in London, I've got 2 extremely talented specialists working with me, and I refer all my root canals to them, and they are truly really talented and really, really good at what they do. And when I refer to them, sometimes I'm lucky that I have someone like Dr. Morteza in the practice with me, and I can show them the case there and then. But if I don't, it's really important that I take a photo, have the x-ray available to them, and then they get to see that. We have a software, so everything, a cloud-based software, so even at home they can log on and have a look if they need to. All of that is uploaded to the software. If you need to refer and then the specialist is not in the practice, you need to consider a couple of things. So sometimes you might want to book in the patient for a consultation with the root canal specialist. And I do it when, even in my practice, when they're in the same building, when the patient wishes to meet the specialist first. You know, those patients that are quite agitated, quite nervous. I think for those sorts of patients, it's better to book them in with the specialist first for a consultation. They get to meet the specialist first before the treatment, and that just calms the whole environment down. If you're unsure about the root canal prognosis, so if you have a look in the x-ray and you don't know if even root canal is possible, that's when I book in as well for a root canal. If a CBCT needs reporting, if you think that the tooth will benefit from having a CT scan prior to root canal treatment, that's when I refer. And discussion of complex options is one of the most important things. So when maybe there's apical surgery involved or complex root anatomy, loads of different options. So these are the 4 main things that I want you to think about when you're referring to a specialist. And when you do write a referral, an external referral to an outside practice or even to a dentist or a specialist inside your practice, you need to make sure that you have a complete case history in your notes or in your referral, the vitality test results from that initial consultation. You need to take a photo so the specialist can see the clinical presentation, how the tooth looks like before they see them, and then your plans for restoring the tooth. And then sometimes they can even comment on whether maybe an onlay or a crown would be better. So this case is by the wonderful Dr. Risha Patel. So this is Catherine's tooth, and this was pre-op, as we've seen already. This was directly post-op. So the tooth has been rewalled, and this is directly post-op, beautiful endo. And then this was only 2 months later. And you can see that that lesion has healed quite a lot in 2 months. And then this just goes to show that following all those rewall steps prior to endo, I think really did help in this situation. And I'm confident to say that if we didn't follow all the steps and just sent this case to the root canal dentist with all that caries in it, the case wouldn't have been as successful. And remember, a root canal specialist or a root canal dentist, someone who just does endodontics, they will not be as confident as maybe a general dentist or a restorative dentist who does fillings every day, who's confident with matrixing, with a rubber dam. So just bear that in mind. We're going to do it a lot quicker and usually more effectively. So just think of the patient as well. And this is how I ask my root canal specialist to temporize after a root canal treatment. So the root canal treatment is done. The root canals are filled with gutta percha. And then I usually ask them to just place a layer of flowable. This layer of flowable, it really doesn't matter what flow you're using. I ask all my specialists to use Clearfill Majesty Flow, a super filled, highly filled flowable, which is the gold standard for most restorative dentists in our practice. And then I ask them to place another layer of PTFE just over the flowable. And then I ask them just to use a more stable temporary material such as GIC compared to, for example, Cavit, to just finish that restoration off. Remember that sometimes you're going to have a short gap between root canal treatment and the final restoration prep, but sometimes the root canal specialist may ask for 2-3 months before you start proceeding with further treatment. And in this case, in Catherine's tooth, we have to wait because we want to wait and observe healing of that lesion. However, if the tooth just had irreversible pulpitis, there's no chronic lesion there, we can go straight for restoration after endodontic treatment. So let's move on to indirect preparation. So in this chapter, we're going to talk about crowns versus onlays, the considerations of the preparation, and just slowly introduce some fitting protocols. And question we often get asked is an onlay good enough for a tooth that's had root canal treatment? And the answer is yes. And this paper in 2021 just shows us the risks of overlays and onlays on endodontically treated teeth, and it is higher on root canal treated teeth compared to vital teeth. However, these statistics are quite impressive, that failure rates on indirect partial coverage restorations on endodontically treated teeth were only 4% after 2 to 4 years, 11% after 7 years, and 21% up to 12 to 30 years. So if a patient asks you about onlays, or why are you doing an onlay, why aren't you crowning the tooth, please just show them. You can take a photo of this slide, please show them this, because these are quite impressive stats, I think. And remember that if there is a failure of the indirect partial restoration, you can usually restore them. So you can either fix it with some composite, you can redo it. Usually it just pings off and then you can re-cement it. And at the end of the day, it does prevent tooth loss. And remember, the good news is that we can always proceed to prepping the tooth for a crown in the future if there is catastrophic failure of the partial restoration. So, and remember, when we're prepping for these teeth, we do not need retention or resistance form when we work with the correct adhesive protocols. There's 2 types of prep that I use when I treat root canal treated teeth. So I call them the core prep and the full prep. One is where we remove the whole core. So we remove the temporary, we remove the Teflon tape, I replace the core, I prep the tooth, and then I finalize the prep. And then the picture on the other side is actually a tooth that I prepped yesterday. And then this is where I prep the tooth, replace the core basically at the same time, and then I finalize the prep. Both of these options are really good. I kind of pick and choose when I do them. The full prep is usually a little bit quicker, maybe, but both of them are as effective as each other. And at the prep appointment, we need to get all of our stuff ready for the indirect prep, get everything out the drawer, get all your burrs out, and then we have to take the impression. This is really important. So we want to make a good temporary. So get a good quadrant impression tray, put some silicone putty in there, mix it well, and then place it into the patient's mouth and just hold it there. Make sure it fits properly. Make sure you're doing the impression well. It doesn't have to be a perfect gold standard impression, but you want to get the general shape of the tooth. If you do have a previous cavity, or if the temporary has fallen out, you can either fill in that cavity with some flowable inside the patient's mouth, or you can get a burr and remove some of that putty once you've taken the impression from inside the impression. Some prep considerations, because this isn't a presentation solely on preparations, there are some key points that we need to understand. So when we're working on lower teeth, we need to think about the lingual cusps, because they're more likely to crack, and buccal cusps on the top teeth are more likely to break. We need to maintain a brio-rim, which is the 2-3 millimeters of enamel above subgingival, above the CEJ. And a lot of the times we can't get a brio-rim all the way around the tooth, but at least if we get it on most of the surface of the prep, we're doing well to transmit the compressive forces. And any cusps that we want to reduce, at least 2-3 millimeters, so we have enough space for the indirect ceramic restoration. And when I prep teeth after root canal treatment, just to play it safe, most of the time I do a full cuspal coverage overlay rather than an onlay. This is just because I'm not sure about any other cracks which might be present within the tooth. If there has been loss of one or more marginal ridges, it's better just to reduce everything down. And remember that you just need to have smooth internal rounded line angles and the enamel bevel as much as you can all the way around the tooth. This not only helps with the bonding, it orientates the enamel prisms, but it hides the margins when you're fitting the restoration. I love using this burr. This is one of the burrs from Maxim Belograd's preparation kit. And there are 2 dots on it, and the first dot is 2 millimeters, the other dot is 4 millimeters. So it gives you a really good indication when you're prepping how much you're reducing the tooth without needing to get anything out to measure how much cusp reduction doing. So you can be quite confident when you're working under rubber dam how much tooth you're removing. And this is the kit. So I use this kit every day when I'm prepping for an onlay, and all these burrs, not all of them are always used, but these are very, very useful. So check them out. So going back to Katerina's tooth. So we've got 2 months later, we've got the patient back in the chair. We've got temporary in place. I've already actually removed that mesial wall because it was quite tight getting the rubber dam on. But I cut it down and took the x-ray, just made sure everything was healing, and then everything looked really good on the x-ray. Patient didn't have any symptoms after root canal. She's extremely happy. And then you can see that that temporary on the top with the rewall is still really nice and stable. And then this is a case where this is a picture to show you how it would look like when you remove that temporary restoration. You hit that PTFE tape that the root canal specialist placed. And that PTFE tape usually does create a really, really strong barrier between the GIC and the layer of flowball that they've placed. And in this case, this is after removing the PTFE, and we can see that rough layer of composite because I've been attacking it with the burr. And then I use Aquacare just to reactivate the monomers within that composite so it's ready for bonding. Then I use gold standard Prime and Bond from Curare, my favorite, SE Protect. And then that's the IDS. And then I use a super filled flowable, clear fill Majesty Flow over that IDS. I use about 0.5 millimeters of it and I cure it. And then you can fill the core of the tooth with a good dentine composite. And I was using APX a lot in the past, and I still do. There's new research that's come out, and there's loads of talk about the benefits of using a fiber reinforced composite. And then that is a lecture for another day. But I do use fiber reinforced composite a lot. And then when we went to Japan, actually, one of the main questions that were asked was about Curare and introducing a fiber reinforced composite. So we're very excited if Curare can maybe make one of these fiber reinforced composites. We do think this is the future. So once we've done the prep, the tooth is ready. This is a consideration you need to consider as well. If you do this technique where you've built up the core first and then you've reduced the walls and removed all the walls that you've rewalled previously, and then you've cut dentine again, you really do need to perform IDS again. And this is important because IDS, immediate dentine sealing, has to be performed on freshly cut dentine. And this overall reduces, if the tooth is vital in between appointments, reduces the sensitivity between appointments when you've got the temp on. But more importantly, it does strengthen the bond long term between the ceramic restoration and the tooth. And just to summarize, this is how I would do it on a tooth that I haven't reduced totally. So this was a vital tooth. And so you use SE Protect. That's the first kind of prime, it's got antibacterial effect, it's really effective, and you have to make sure that you scrub, especially on cavities like this where there's a lot of caries present. You scrub it in really well, and then you just air dry it a little bit, and then it's time for the adhesive layer. So you use SE Protect, and then you scrub that in, and then you cure it. Then it's time for the resin coat with Majesty Flow, and then I apply about 0.5 millimeters of it, and then you fill in any undercuts. As we haven't reduced some of the cusps in this prep, fill in any undercuts with some APX, and then I refine the margins of the preparation, especially on the enamel, and then I polish the whole thing down. And then once it's polished, your prep should look something like this. When your prep is finished, it will look something like this, and it's ready to scan. Some of you may be asking, what is that little circle in the middle of the prep? I call that like an orientation pimple or an orientation dot, and then that is helpful for me in some cases when I've prepped the tooth right down, and when it comes to the fit of the indirect ceramic, I'm worried about it sliding across the whole preparation. And with that pimple in place, you can slot it in like a jigsaw puzzle or a piece of Lego, and you know that you're in the right position. So you'll see all your margins lined up, but most importantly, that little dimple that you're going to have in the ceramic will fit right into that slot in the preparation. In my clinic, I use iTero, and a lot of the time I scan under rubber dam, and the software is really good on this scanner that it overlays the prep tooth under rubber dam on the full arch scan. And this is really important that we scan the prep and then we scan the whole arch just to get the occlusion, so the technicians can design the ceramic well with the inclusion in mind. And by doing this, you can see there's enough clearance on the scan. We've got the full arch scan, and the technicians can design it with good anatomy, and then 9 out of 10 times we've got a really nice fitting onlay, and the rubber dam helps to reveal those margins. There's no leakage, there's no saliva, there's no blood, and we're able to get a really nice scan of the prepared tooth. Remove the rubber dam, scan the top and bottom arch, take the buccal scan, and then send it off to the lab. And then 9 out of 10 times when you do that, you will have a great fitting indirect ceramic with little or no adjustment required. I want to share with you, and this is a question I get asked all the time, I want to share with you a tip about temporization. And one thing that, if you take one thing away from this presentation, I want it to be this. This is the impression. I don't use the whole impression when I'm actually making the temporary. So I get a normal scalpel or like a blade from your local DIY shop, and then I cut the impression. I take it out of the plastic tray, and then I cut the impression halfway or a little bit less than halfway across the adjacent teeth. So I'm just focusing on that prep tooth. It looks something like this. And then it's really small. We're able to handle it quite well. And then we can put it in the mouth without any struggles. Sometimes, and I've had this in the past myself, I've struggled to sit the impression on the patient's teeth, and then I have to redo the temporary, and then it means wasting more material, wasting the patient's time, running late. The nurses miss lunch and they're angry at you. So doing this, you're able to actually visualize if you're seating the tooth correctly, because you've got the tooth cut half, the impression, sorry, cut halfway along the adjacent teeth, so you can visualize everything. I use a bisacral material, and then I place it into the impression, place it on the tooth, leave it there whilst holding it down nice and tight either side and from the top, either side for 2-3 minutes, maximum 4 minutes, and it will set and it will eventually shrink fit. Before you do that though, it's really important that you make sure that the temporary doesn't stick to the prep tooth permanently. As you know, we've done a resin coat, so there's loads of resin on that prep. So we don't want the temporary material, the resin bisacral, to bond with that tooth. And believe me, it's a nightmare when you come to the fit appointment and that temporary won't come off. You want to quit dentistry, you want to throw yourself under a bus. So just remember these few steps. So once you've prepped the tooth, you can cure the tooth with cure the prep with under glycerin. That will help as well. But this is how I do it. So you apply a little bit of etch after you cured it with glycerin, just to reactivate the bond of the composite, and then I apply a little bit of bond in that exact same spot where the etch is, and then I apply Vaseline to the periphery. And this is the key: apply some Vaseline to the interproximal walls of the adjacent teeth, and then I place the impression, and then this is how my temporary comes out. And you can see that this is without any sort of excess removal. This is right after placing the impression on the tooth. And we've got a nice, clean temporary. And we do have to remove some excess. But remember that it's a lot less than if we were to use a whole tray. So be sure to give it a go when you're next time prepping a tooth for an onlay. And this is how the temporary looks 2 weeks later. For them to stay on for a non-retentive prep, please ask your patients not to floss in between those gaps for 2 weeks. Nothing's going to happen. They're not going to suddenly develop chronic periodontitis because they haven't flossed for 2 weeks. I know a lot of people that don't floss at all and their gums are fine. Please don't tell your patients that. But this is 2 weeks later, and then you can see that the soft tissues are looking reasonably healthy. The temper stayed on, and then that I think is the most important thing, that the temper stayed on, and then the patient doesn't need to come back and see you to refit a temp or remake a temporary restoration. So everyone's happy. And then now it's time for the fit. So 2 weeks later, we come back for the fit appointment. So after scanning and prescribing what you want, in this case, lithium disilicate overlay for Catherine's tooth, medium translucency for a root canal treated tooth. We're going to go through some cementation options, the use of heated composite, and how I do the fit, what protocols I follow, and how I cure. So there's loads of cementation options out there, and then these four are the main ones that I've used in the past. So I've used Variolink Aesthetic, Dual Cure. I've used a Light Cure version as well. I've used Panavia self-adhesive cement, which is great. I've used Panavia V5, which also is great, and I've used the legendary Panavia F, which is also great. I mainly use Panavia F for zirconia crowns when I do them. I've used Panavia V5 for veneers, and I've tried self-adhesive cement for onlays, but my favorite way of cementing and bonding my glass ceramic restorations is with heated composite. And my favorite composite to use is Clearfield APX. And we were lucky enough to see and meet the person behind it out in Japan. And the way to use it, you need to heat it for at least 10 minutes at 68 degrees. So from a practical point of view, when the patient arrives for your appointment, you don't want that APX to have been sitting there all day. So if your appointment's at 4 o'clock, don't put the APX in the heater at 9 a.m. in the morning. You do not want to leave it in the heater because it can polymerize by itself if it's left in the heater for too long. So you can waste a lot of good material by just leaving it in the heater. So I actually, when I do normal routine dentistry, I don't heat this material at all, because after about 30-40 minutes, you'll try to squeeze the composite out of the compule and it's completely hard and it's not usable. So 10 minutes. So 10 minutes before you're about to fit the restoration, get that composite in the heater. And the benefits of using a heated composite, there are many. So we're very familiar with such materials because we use them in direct restorations. We know the colors, we know the shade. We can light cure it on command, so we can move the restoration as much as we need. We can check the fit of the restoration. We can make sure it's seated properly. We can make sure that we've removed as much excess as we could. And it's very predictable removing the excess because it's a composite, again, that we're familiar with. So we're familiar with its viscosity. The mechanical and physical properties of it is much better than normal luting resins, and the wear resistance is higher compared to the resin cements that we usually use. So back to Catherine's tooth. This is a tooth when the temporary has been flicked off. We've obviously put some rubber dam on and isolated the tooth. And in some cases, I use a floss tie. In the majority of cases, I don't. And it's better actually if we don't use a floss tie over the prep tooth. And we need to reactivate the bonding because we've previously cured it. So we need to aerobrade this preparation. It's been under a temporary restoration for a couple of weeks. So we need to aerobrade it and expose the unreacted double bonds in the composite. So we need to use 29 micron aluminium oxide, and we do that until the prep is clean, as you can see in this picture. We need to etch the whole fitting surface after this. So we use phosphoric acid, the blue etch, and we do that for 30 seconds. And then the next stage, this is where I apply Teflon to the adjacent teeth. You can use Teflon, you can use plastic cellulose band, you can use a metal band, it really doesn't matter. I prefer using Teflon because number one, it looks great on pictures, but also you can adapt it to the shape of the adjacent teeth, and every tooth has got a slightly different shape. And then once we've aerobraded, once we've applied the Teflon, that's when I apply the adhesive. So I use the second bottle. So I use the bond from the SE Protect system. So the SE Protect bond, the adhesive, and I apply that onto the tooth and I left it uncured. We want the ceramic to bond to the IDS, not to the dentine ideally. Another tip to make sure that we have the ceramic really, really nice and clean. I like to, when I get it back from the lab, one of the first things I do is apply some katana cleaner, which is another cool material from Kure, and it removes contaminants from the fitting surface of the ceramic. But the cool thing about it is it also can be used intraorally, not only extraorally. So it's safe to be applied directly onto the tooth. So under rubber dam, you can then clean that prep, because over time, over the 2 weeks while you've been waiting for the lab to make the ceramic, it's had a temp on it, saliva has contaminated it, blood can get on it. And then these are the steps that I follow for the ceramic. So this is when the patient's lying in the chair with the Teflon on the adjacent teeth, with the uncured resin on the tooth, on the prep tooth. And then this is what we do on the side. And you have to mention this to the patient that we're going to be doing some things outside the mouth. So greater than 5% hydrofluoric acid, and that dissolves the silica matrix. And then as you apply the hydrofluoric acid onto the ceramic, there is a reaction, and hexafluorosilicate salt is formed on the surface, and using 37% phosphoric acid then removes that salt. And then finally, you use a primer, and then my favorite, and that's silicization, and my favorite ceramic primer is Clearfill Ceramic Primer Plus. And what I do is I do not air dry it, so I apply it onto the tooth, onto the ceramic, and then I let it evaporate, or sometimes I even place it on the heater. And then that way, when the ceramic's slightly warm, then you might not risk, because the ceramic sometimes can be cold, especially if it's been outside or it's just been delivered. It can then make the composite actually set a lot quicker, the heated composite. So now we're ready to bond. We stuck the tooth on, we've stuck the ceramic onlay on, and then we've got the squish. We've got the squish all the way around the tooth, and this is where we can start removing the excess. The material is very, very flowable at this point because we've heated it for at least 10 minutes. And then we can use simply a sharp probe. This is a fissura from Style Italiano, and we can remove the excess, the bulk of the excess, using this. I use 2 of these probes, so I've got one pressing constantly on the occlusal surface. I use the fissure as like a catch point, and then I make sure I keep pressing from the top, and then I use the other end just to remove the excess all the way around the tooth. And then it's quite simple because we know the material. And then just a quick tip, sometimes I apply modeling resin to the sharp tip of the probe of the instrument, and then that just helps the material not sticking, the composite not sticking to the material. And then I also apply it to a TP brush, and then we can go interproximally once the bulk of it is being removed. Once you've removed the excess, you need to then follow a robust curing protocol. So I continue applying pressure occlusally, and then it's really important to then cure really, really well. And this is where your nurse has to come in. So you continue applying pressure occlusally, and then you have to cure from different sides of that ceramic. So I do 60 to 90 seconds of both the lingual, the palatal, the lingual, the buccal, and then I'll make sure that's cured for that full amount of time. If you have 2 light cures, you can do it both at the same time. And then I make sure to cure the interproximal areas for the same amount of time. And then I do one final cure occlusally. And then this is the final step. So this is the final cure. We need to then apply glycerin over all of the prep, or over all of the ceramic, over the margins. And the reason we apply glycerin is because there's a free monomer of uncured resin left after curing. And when we cure through glycerin, this eliminates this layer. And this just makes life easier for us when we come to polish off those margins. We don't want any uncured resin left on that ceramic. So this is the final cure under glycerin. And as you can see, even after removing the bulk of the excess, there is still bits of flash excess material left on the ceramic. So we can either use a hand scaler or an ultrasonic scaler. I love using my favorite floss, Gorilla Floss, just to help remove the excess. Another thing that I love to use is using a serrated interproximal strip. A metal one, I use maybe a fine or a medium grit with holes in it, and that just helps remove just the excess resin. It doesn't damage the teeth. And if you want, you can use like a 12 blade scalpel. And then this is the final side profile of the indirect ceramic restoration. And it looks pretty good. The margins are stable. There isn't too much excess. And then we can remove the rubber dam, do a final check. And then this is the post-op x-ray. And I would urge everyone to start doing this because it's really, really cool to see how your margins are clean. And it's really easy. If you do see a bit of excess on the x-ray, just get a blade to it, get some Gorilla Floss, get whatever you want, and start cleaning those interproximal areas again, because that will come off eventually. It's not the end of the world though if you do have a bit of excess, because I think eventually it will come off. If you've got a big chunk of excess material, excess resin, that is more of a concern, especially in terms of food packing and inflammation around the soft tissues. So this is the whole workflow. So this is where we started from, where we had the massive area of decay, the suboptimal root canal treatment, and we go through the process. We scan the tooth, we do the root canal, we scan the tooth, we do prep the tooth, we scan the tooth, then we come to fit the tooth, and then this is the before and after. I think reviewing cases like this is really important, but unfortunately Catherine fell pregnant right after we bonded this ceramic onto her tooth, so I haven't managed to see her yet, but I do treat her husband now, and I saw her the other day with her baby outside the practice, and she seems absolutely fine. I did ask about her tooth and she's having zero problems, so happy days. And how do we do a review? So I think it's really important to see patients once you've done a case like this, especially if it is a root canal treated tooth. So obviously taking an x-ray, so this is an example of an anterior root canal, and then you can see just 8 months later the lesion healing, and showing this to the patient will not only build your relationship in terms of trust, but then they'll also just think to themselves, do you know what, it was money well spent, it was worth coming to this practice. So they might even refer more patients to you. You can even take a photo if you want, but it's more important taking a photo when you're working on teeth in the aesthetic zone. So this tooth was following trauma and it had some problems, and it had root canal, and it was discolored. We did some bonding. The patient didn't want to do internal bleaching at the time, but then we reviewed the patient 8 months later. There was a slight little chip on that mesial edge of the upper right one, but the patient wasn't bothered. He was happy. There wasn't any chipping. I asked him again about the upper right one. Does he Is he concerned about that? It's slightly a different shade to the other teeth. He wasn't. So then I'm not going to force the patient to do any internal bleaching or more whitening because the patient's happy. And remember that at the end of the day, that's what we want to achieve. We want to just have happy patients. And then this is a recall of a posterior onlay that I did. So this is another root canal treated tooth. And this is right after bonding. So you can see this layer of composite. You can see the margin. And I think I did polish it a little bit more after taking this photo. But the cool thing is that 3 years later, it managed to polish itself. And this is because the patient, elderly gentleman, probably brushing a little bit too hard, and it's just removed that excess as well. So that's what I mean about not worrying if you, on that stressful fit appointment, you haven't managed to remove the excess, because it will come off eventually, even just with normal toothbrushing. So the core takeaways of this presentation, hopefully, just be prepared and examine, document, diagnose, discuss, and plan. And if you follow these rules, you're going to have a really, really smooth sail for your endodontically treated teeth. And it's going to be easy, not only with the specialist, but with the patients. Give the tooth the best chance. And if you put more time in, remove the caries, re-wall, the RCT will be better. Your treatment outcomes will be better. They'll be more predictable. You won't end up with any, hopefully, fractured cusps or broken teeth. The patient will be happier. You'll probably make a little bit more money because you're seeing the patient a bit more. I know that's not the aim, but remember, that's more, sometimes it's more time consuming when you're dealing with, you put a temp in and then the temp's broke, the tooth's broke, then you've got more of a angry patient to deal with. And it's worthy of investment to the patient. Remember that you need to explain it in a way that having that pre-endo appointment is worth it and it is important. Please treat the patient and not the tooth. So if the patient is scared of root canals, doesn't want root canal, has had root canal in the past, didn't have a good experience, and would rather extract the tooth, let them extract the tooth. It's their tooth at the end of the day, and put their best interests first. So if you see a tooth that you know can't be restored, or you're worried about the restorability of the tooth, please be honest with them and say, look, listen, it's not wise you putting in a lot of money into this tooth. Just get it extracted, and then having an implant might be the better option. Discuss these cases with your root canal specialist or other restorative dentists if you're unsure as well. And then finally, when you restore the tooth, just think about all the biological considerations. So when you choose between an onlay and a crown, think about everything, not only about the soft tissues, the amount of tooth left, but think about if that patient, if you can isolate well on that patient, if you think that patient might not tolerate sitting in their chair for so long, because I think an onlay prep is a little bit longer than, and applying rubber dam is a little bit longer than just doing a standard crown prep with an Optragate. And try and emulate the biology, emulate the function and aesthetics, even of posterior teeth, because the patient won't see it, but you will. So every time you see that patient for a recall, you'll have a look at that tooth and you can be proud of your work. So just remember that, and then make sure you have fun. These are only teeth, so please do not stress. So at the end of the day, even if your onlay fails, you can either redo it or you can do a crown. And remember, most of the time the root canal fails, so it's not even your fault. So hopefully you've enjoyed this presentation, and thank you for listening. It's quite late. I don't even know the time. So it's gone just 9 o'clock UK time, so just over an hour. So thank you so much, and I'm so excited to hear all your questions.
Okay. So, Dr. Wiktor, if I may ask you to display your screen, please, because we are missing you. Yeah. Okay. We see you right now. Well, so I'm not really happy to say that we approach to the end, and just in a simple way, I'm really expressed, and I'm trying to find the right words to express my gratitude for your excellent presentation. And it's always a pleasure to listening to your lectures and talk to you. And I hope all these techniques and advices from your session will be implemented immediately to the dental offices for those who are here with us. And by the way, great photos. And is that your new camera you bought in Japan?
Oh no, some of them, there was a few photos from the new camera, but most of them are from my old camera. But if you want to learn more about photography and then how I took those photos, please just message me on Instagram. And then you can come on our course with the great Minesh Patel to learn more about photography.
Okay, I think that everybody really appreciates the quality and the shapes of the photos you have. So great, Wiktor. Again, thank you so much for this great presentation. And shall we move to the Q&A session right now? Because I think that we have a couple of questions from the audience, and I received a few questions from the private chat. So let's go through. Just let me double check the question. And the first question from Cosmin: when the tooth is restored with a pre-endo buildup before the endodontic appointment and the endo treatment is taking place after 1 week after the pre-endo buildup, do you recommend to restore as much as it can be with composite and at least possible amount of provisional temp filling cavity to prevent breakage of the tooth during the period? Thank you.
So
what do you think about this question?
As
kind
you
of
saw,
extended question, to be honest.
As you saw in one of the photos, I showed you where I saw a patient the other day with a very large temporary restoration. So that was a lot of temporary material, and that tooth ended up fracturing to possibly an unrestorable state. So I really like to build up the tooth as much as I can with composite, and then just utilizing a very small area of temporary restoration. So then the endodontist can visualize and access the root canals very easily. And just remember that you're going to, in the majority of cases, remove all that composite that you've placed anyway. So if you are unhappy about anything that you did during that the rewall appointment, you're going to be redoing it anyway and covering it with a ceramic restoration. So do not stress, but try and get as much composite into that pre-endo buildup as much as possible. But the most important thing is ideally do not leave a marginal ridge with just a temporary restoration. Try and re-wall it, not only for the strength of the restoration, so the fracture resistance of it, but for the leakage, so there's no leakage in the interim, because that can become a problem, and it will just make the root canal more predictable for the root canal specialist and for the patient long term. So yeah, place as much composite as possible and the least amount of temporary restoration.
Well, nice. I have no doubt that there is any other question about that. So thank you for this explanation, and let's move forward to another question. And the question is from Galina. And thank you for this question. Which material do you use for your temporary restorations?
So it's a bisacral resin, but the brand names, if you want to know, I use in one practice, I use Luxatemp, which is probably quite well known. I believe it's from DMG, and unfortunately, I don't think Cure does any bisacral resins. But so I use Luxatemp from DMG, and it's got quite similar handling to ProTemp, which is quite familiar to everyone as well. And in my other practice, I use Structur, which is another bisacral resin. So it's a simple kind of double cartridge injectable resin material, and it really does work quite well. And then one thing to add when you do your temporaries, both on the front and on the back, if you just get your finger, and this is what Maxim Bellegrad taught us at his course, just get your finger right after you've placed it and just give it a wipe. He called it the magic finger, and that really does help just to give it a polish, and you don't even have to like adjust it with polish it down with a burr or anything else to make it smooth. So Luxatemp or Structure or any other bisacral resin material.
Yeah, if I'm not wrong, it's L'Occitane from BMG.
Yes.
Okay, so when it comes to the materials, we have another question about the company and also the name of the self-etch, self-adhesive material, I think. Voco Bifix SE. What do you think about this material, Victor?
Voco Bifix SE. I honestly have never used Voco Bifix SE. I've used some Voco materials. I've used Voco Grandioso, which is a very similar composite in terms of properties to Clearfill APX, and that I think modulus of elasticity is very similar to APX. So the reason we use APX is because mainly due to the mechanical properties of it and its similarity to dentine. But in terms of the self-etching system from Voco, I have not used it. I just know from the people that have taught me and the biomimetic dentists that I look up to and I've learned a lot from, they all say that the gold standard 3 bonds that they would use are SE Protect from Kure, SE Bond from Kure, and one from Kerr, which is OptiBond FL. And I have used all 3 of them and I'm very happy with the results. The main difference and the reason that I use SE Protect is because of that extra MDBP monomer, which has that antibacterial effect in the cavity, which is really, really good, I think, in terms of cleansing any bacteria within a very carious tooth. And if you use a good self-etching system, just please remember, do not over-etch the dentine. Sometimes some dentists do etch the dentine for a short amount of time, but I just etch the enamel when I use those bonding systems, when I use self-etch bonding systems. Remember that OptiBond, gold standard also, bonding system is a total etch system, so you have to etch the enamel and the dentine, so the prime does not etch the dentine.
Okay, great. Nice explanation. And if I may add something, regardless of the material and the company in this question, I think it's also important to double check the chemical compounds. So it comes to the MDP, if it's inside or not, and other solutions, what can be also beneficial for the patient and also for our restoration and long-lasting results. Okay, let's go further because I think that we have more questions. From Michał, so from Poland. I'm so happy. Do you remove all
Hello,
excess of the semen before curing, or do you tack cure? Nice question.
So with heated composite, I do not tack cure because ideally you need to cure for 20 seconds, and if you do have a powerful light cure, you're going to end up curing everything at the same time. Because usually lithium disilicate is also slightly translucent, so it lets the light pass. That's why you can light cure, but I do not ever tack cure when I'm using heated composite. I have done it with other light curable resin cements. I just find using heated composite, like I mentioned in the presentation, a lot more predictable in the way I handle it, and I think that is really important, that when you're fitting or seating a restoration, you want to be sure that it's seating correctly. And there has been studies by numerous people, and the back of my head, I've got one from 2018 by Pascal Magnier, where he compared the use of using resin, cement, standard luting resins, and heated composite. And heated composite outperformed luting resins just in terms of seating, and then that's what makes me worry a little bit when I'm using a light curable standard luting resin, that if I tack cure it, I think it will be quite difficult for me to manipulate, and the handling time is a bit short for me, so I really do prefer using heated composite. But yes, when you're using a standard luting resin based on the manufacturer's instructions, please do tack cure if it is recommended. And I think in some cases, especially anteriorly, I think it's much easier to do, like from a practical point of view. I'm a very practical dentist, so I want to simplify as much as I can. So yeah, I don't tack your heated composite, I'm afraid, because I don't think it's really the suitable material to do that. So, and also there was another part of that question: do I remove all the excess of the cement before curing? Yeah, so I remove as much as I can, so the bulk amount of cement, and I work on the loop, so I can see as much as I can. However, I'm not perfect, no one's perfect, so there is always a bit of excess left over, and then that's why I use things like Gorilla Floss, the serrated interproximal strip. I use an ultrasonic scaler, and I use a blade sometimes, and I do that all before I remove the rubber dam. And then I double check this again once the rubber dam has been taken off. So I floss again, and I check for any excess. Then I double check that once again by taking an x-ray. And then by taking an x-ray, you know confidently that you've removed all the excess. If the patient is running late and you need to send them away, or if you're running late, just tell the patient to come back. It honestly isn't the end of the world. Nothing's going to happen.
Thank you, Michael, and thank you, Victor, for your explanation. I feel that you are explaining very deeply all the answers from your side, which
Yeah.
will be highly appreciated by the audience, I think. And okay, the question from Ahmed: do we have to air abrade our glass ceramic restorations too?
So this is an interesting question because I used to aerobrade the glass ceramic restoration. So I used to abrade when you flip it over and then you look at the glass ceramic, and I used to aerobrade that surface. But then I was told not to aerobrade the surface of the restoration. And then the most important thing you need to ask is you need to ask your technician if he's doing it. And then most of the time that the technician has actually done it for you. But also the fact that there's really nothing, there's no purpose to it really, that you can clean it, but you can, if you want to clean it, you can use like katana cleaner on the surface of the restoration. But the main reason why you aerobrade the prep is to reactivate those monomers in the composite after you've done IDS and your resin coat. So aerobrading and roughening the surface of that ceramic, you need to find out whether your technician is doing it. If you're doing a crown, if you're doing a zirconia crown, yes, you need to aerobrade it. But then also you do need to ask the technician, because when I worked with a technician in Malta, the technician was aerobrading the inside of the crown. But then in London, they don't. So then I have to do it. So the glass ceramic restoration, I do not personally aerobrade it. And touch wood, I've not had, the only debonds that I've had following this protocol are because of my mistakes. And then this was a few years ago now, when I didn't take into consideration if parafunction, so bruxism, if the patient was overloaded in the occlusion, so missing adjacent teeth. And then that's where a non-retentive partial restoration is maybe not the best it's not the best indication. And if you're ever worried about the ceramic fracturing or coming off, please do a zirconia restoration. Make it out of katana zirconia from Kure, because we've seen them being made from like the powder to the Japanese ladies having a look at them and making sure that they're not damaged. And I guarantee you that they're more likely to break the opposing tooth than the crown itself breaking. So yeah, I do not aerobrade the glass ceramic restoration, the surface of it, just the tooth.
Okay, Victor, so if I got you correctly and I understood your also the presentation, do you think it's a good solution to use katana cleaner instead of air abrading for those who doesn't have air abrade in the dental offices?
No, so the air, like you should be aerobrading because because it does reactivate the bonds. So even if you don't have an expensive aqua care, you can use like a standard sandblaster. And then I've got a normal sandblaster in my other clinic, and that's fine. And it's just got the 29 micron aluminium oxide, and it's shooting out. It's getting fired at high speed at the tooth. And then that's when I reactivate the monomers in the composite. But if you want to use katana cleaner, I use it now in every case. So I apply it both on the tooth after air abrasion, and I apply it on the fit surface of the ceramic. And then that way you can remove any contaminants on it. I have used in the past as well. And then some of you may be thinking, why isn't he putting it into a bath, into an ultrasonic bath? And I have used that, and then that can be done after you've applied the hydrofluoric acid and the phosphoric acid, just to make sure that you've removed all the salt crystals on the surface of the tooth. But I've stopped doing that, and I think katana cleaner, I don't know, I think it's just as effective, and I haven't seen a difference. I haven't had more debonds because I haven't been using an ultrasonic bath. So yeah, if I start getting loads of debonds, I will probably start reconsidering how I do things. But at the moment, I think I don't need to.
Okay. By the way, this question comes from my side because actually this material is getting much more popular than before. And now when I talk to my dentist I work with, they highly appreciate this material in case they do not have this solution with air abrasion.
And remember
you
can use, and then katana cleaner is good, even though it's called katana, which is katana zirconia, but you can use it for all types. You can use it on feldspathic porcelain, you can use it on lithium disilicate, you can use it on zirconia. So it's quite a universal cleaner, and when the best kind of positive thing about it as well. And when I mentioned it to a friend of mine recently, he was shocked and he was really surprised that it's got that application that you can use it intraorally as well, which I think is wicked. And then, yeah, so.
Yeah, that's true. It makes it a unique material while you can apply it intraorally, not only extraorally.
Yeah.
Okay. Very long explanation. I do appreciate. Let's go further. And I think we have the same question. I mean, from Ahmed. Is type of composite that you used for cementing make difference, nano or microfilled? What do you think about this question?
So there's been loads of studies to kind of question this, and the reason that I use APX is because I'm not the one researching it, so I'm just listening to everyone that does the research, and there's so many people much more clever than I am who are telling me to use APX, so I use APX. But I've used other composites in the past when I did not have APX, and those onlays seem to be fine. And I'm not too sure, and don't quote me on it, I'm not sure, and I'm not confident to answer this question properly if a composite is a certain type, because I haven't memorized every type of composite. But as long as you're using a composite that you're familiar with, and I used to use Empress Direct from Ivoclar, and the color stability in that composite, similar to APX, was very good. The handling was very, very good when it was heated. So I'm not too sure if it makes a difference. But the reason that I love using APX is because when it is heated, just for those 10 minutes, it becomes a highly flowable composite. But it's still really manageable, and it's very easy to use. But I have used other composites. I've used Voca, I've used Empress, I've used even flowable resin to cement onlays. So as long as you do all the steps as well, remember that it's not only about what composite you're using, but during the preparation about your IDS, your resin coat, all of those steps are really important as well. So it's not only about the type of composites. That's what I mean. If you're using a different type of composite, if you don't have APX, please try a heated composite method. And this is just how I do it. So I want you to continue doing what you're doing if it works for you.
Okay. Thank you again. And I feel that we are approaching to the end of tonight's webinar, and I don't want to go through all the questions because I think that we have lots of them, but I will allow myself to go through the one from Adriana. So before you fit your temp, you spot etch and apply bond in that one spot. Did you light cure the bond right away before applying the Vaseline?
Yes. So I didn't mention that in the lecture, but yes, I do.
Question.
Yes, I do. I do spot etch, and then the reason I spot etch, and then I was asked this actually when I was in Japan. The reason I spot etch is because when you apply glycerin and then you cure under glycerin, you've deactivated everything. So there's no uncured resin layer anymore. So then nothing will bond to that. So even when you use bisacril resin, that likelihood of that sticking well it's not going to be very good. So that's why I spot etch in just one area, and it's a similar principle. So when you're doing like porcelain veneers on the front, you need doing temps for that. I spot etch to just activate that one area. Then I apply bond. Then I get my nurse to cure for 10 seconds, and then I apply the Vaseline in the periphery, and then I do the impression.
Okay, and I see another question from Ahmed. So it will be the last one, I promise. During the cementation, do you cure the adhesive layer separately or cure the whole adhesive composite together?
So when I apply the adhesive onto the tooth, I do not cure it, and I leave it uncured. And there's loads of answers out there. You can Google it. It's very difficult to explain, but it's handling is important. But then there's also a lot to suggest that a lot of the manufacturers actually say when you apply the bond onto the tooth, you should be curing it straight away before you then apply composite on top. Some schools say to leave it uncured and then apply the composite and then cure with the composite. So there's loads of different schools. I was just taught from the very beginning to leave the adhesive layer uncured, and I've been doing that ever since. So if you do, and I used to cure the adhesive layer, and again, it didn't make a difference to the overall outcome. But yeah, if you haven't tried it, just give it a try. And then I'm just going to answer this question. So cementing session with all the photography, how long does it take? It takes 45 minutes to an hour, depending on the difficulty of the case. But yeah, photography is easy when you practice.
Okay, so as I promised, it would be the last question. So let me say again, thank you, Dr. Wiktor, for this excellent presentation, and I hope you have enjoyed your time with us, the audience, and let's stay in touch. Of course, don't forget to follow us on our social medias, and of course, you can find further information about upcoming events, also the webinars, and of course, we have more questions, but I will allow myself to publish them on our group. So do not hesitate to ask any questions afterward. And of course, we're going to bring you closer to the answers. So again, I wish you a nice evening, and thank you, Wiktor, for great presentation, and see you soon.
And if anyone's got any questions, just please reach out to me on Instagram, or you can email me, and I'm more than happy to answer the questions for you. And a lot of these cases, like that case, for example, is on my Instagram and it's described. So you can go back and look through my Instagram and find it.
Exactly. Let's do so.
Right.
Okay, great then. Okay,
Good night,
again, wish you a nice evening, and let's stay in touch. Bye-bye.
Thank you very much. Bye-bye. Ciao, ciao.
See you.